Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your co-host, Brian Waterman, a sports and shoulder elbow surgeon at Wake Forest. And I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co-host. Peter, how are you?
Oh, I'm doing great. I'm really excited to do this with you.
Yeah, as am I. As am I. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect that of the ASES, University of Utah, Wake Forest University, or any of the institutions of our guests. Today, it's really our pleasure to dive in on a topic that I don't think gets enough bandwidth that it deserves, and that's that of posterior shoulder instability. I often refer to this as the dark side of the moon, but rest assured, we have two experts in the field that are going to help to shed light on the topic, and they have just a wealth of experience. The first of which is no stranger. It's Dr. Jim Bradley. He's a founding member of Burke and Bradley Orthopedics, clinical professor in orthopedic surgery at the University of Pittsburgh Medical Center, and team physician for the illustrious Pittsburgh Steelers. Dr. Bradley, welcome to the podcast.
Thank you for having me. Appreciate it.
Not to be outdone, for our next guest, we have a good friend and former military colleague, Lance LeClere. Lance is a professor in orthopedics at Vanderbilt University Medical Center. He's a former Naval Academy team physician, and he's a current head team physician for the Nashville Predators. Lance, welcome to the podcast.
Thanks, Brian. It's really an honor to be with you guys. Looking forward to this discussion.
Yeah, let's lead into that. So when we talk about posterior instability, this is a little bit of a different animal. So I just want to level set the topic here. Lance, what are the archetypes you see that come in presenting with posterior shoulder instability?
Yeah, I think some of it is colored by my experience in the military, and certainly, when you're a resident studying for the OIDA, you hear you see the classic questions of, either seizure activity or electrical shock leading to posterior dislocations, and you can get a false sense that that's how posterior instability presents the majority of the time. And I think, for most of us in practice, especially those that treat young, active individuals and athletes, really it's a presentation of somebody who spends some of their athletic career or a lot of their time in a forward flexed, adducted, internally rotated position with their shoulder with relatively atraumatic onset of shoulder pain. And they may not necessarily present with instability, and they may present with, primarily complaining of pain. And certainly in the military, that's a young, active military athlete, late teens, throughout their 20s, that does a lot of push-ups, or your classic offensive lineman. And so, those are the key things I think that I see in my clinical practices. They're not going to show up at your doorstep saying they've dislocated their shoulder necessarily, but you got to have your antennas up for that posterior instability with that kind of demographic that we described.
That leaves us,
Yeah.
that gets us like a typical patient here. Let's talk about that patient shows up to your office. Jim, walk us through the clinical evaluation. Tell us, what do you do in the history and the physical that, really helps you to zero in on this problem?
Well, it depends if they're a contact athlete or if they're a thrower. They're two different things. So let's just set the stage. In 1993, Jim Taboni and I wrote an article, and we said that you guys are missing the point here. Posterior labral tears and subluxations are more common than anterior. So we recently published an article in AJSM, 1,750 some people, and we basically showed that in my practice from 2006 to then, only a third of them were anterior labral problems. Everybody else was posterior. Not meaning they're posterior dislocations, but they're posterior instability. We just followed that up with 2,010 of them. And basically, if you're an athlete, your chances are a third in the front, three-fourths in the back. So people don't understand that posterior instability is way more common in athletes, and it's not a true dislocation. It's usually repetitive posterior subluxations. So there's throwers, and then there's football players and contact athletes. Those are two totally different presentations. So do you want me to continue? I don't want to. like hog this.
No, I want to keep going. I love this. Keep going.
Okay. So here's the big five. Okay, we have it's called a pit slap instability test. We have 5 of them. This is what you hear from the throwers. I can't warm up. I'm hearing clicking and clunking. I can't throw an inside slider because it raises too high. I'm losing my ball high and outside, and my velocity goes down. That's what happens in a thrower. In a football player, what happens is they can't engage in their blocking like offensive linemen because of all the, they weightlift a lot, but they can't engage because their shoulders slipping out the back. True posterior dislocations are extremely rare. And I've seen a bunch of football players, but like Lance has said, electrocutions or things like that. They're seizures. But the spectrum is huge, and you treat a baseball player and a thrower totally different than you treat a football player when you operate on them.
Yeah, I will just follow on to that. And, there probably wasn't a clinic that went by at the Naval Academy where I didn't think about something that Dr. Bradley's taught us about posterior shoulder instability. I mean, it's so ubiquitous in the military population. We looked back similarly to Dr. Bradley. We looked back at our surgical cohort over a several year period, and well over half involved the posterior labrum. So if you're going to treat shoulder instability, you really have to have the ability to evaluate the posterior labrum both in the office, but also during surgery. You got to look back there. You got to be ready to evaluate it, and more importantly, treat it, because it's going to be there. And if you're not seeing it, you're missing it.
Yeah, I've certainly seen that as well, Lance. You and I come from a very similar background with a military patient population. That's where we really cut our teeth on this concept. And it's definitely seeing you if you're not appreciating it. So how are you assessing this? Maybe your top 1 to 3 physical exam pearls for how you pick this up. Is it jerk test, Kim test? Is there something else? Seated, supine? Maybe walk us through that. We'll go with you first, Lance.
Yeah, I think classically it's going to be I kind of combine a lot of the maneuvers into one with the Kim jerk and a posterior load and shift. And then there's additional tests, for other areas of the labrum incorporated into all that as well. The dynamic labral shear test, O'Brien's, and then of course testing apprehension and relocation as well is important. I feel like they've got to be pretty unstable if I'm going to be able to get them, get a positive load and shift, or have an unremarkable ability to relax during the clinical exam. But those are some of my workhorses. I know Dr. Bradley's written a lot on the pit exam maneuvers, and that certainly helped my clinical practice too.
Yeah, Jim, can you shed some similar light on this? We've learned a lot at how
Yeah.
you've
So
evaluated the continuum.
So for whatever reason, no one liked posterior instability in the beginning, and I was not enamored with anterior. I was enamored with posterior, and so we developed what's called the Pit Slap 5-pack. And I can't show you it because it's over the phone, but we're publishing a paper that shows if you have 4 of the 5 of these, your chance of having a significant posterior labral tear is really high. And we're publishing it, I think, in AJSM or in OJSM. But it's really sensitive in athletes. I'm not talking about like people that get electrocuted or they get seizures, but in athletes, it's extremely sensitive. And if you have 4 out of the 5, you need fixed. I'm just telling you, you're not going to get better with physical therapy. And we kind of developed them over a period of time. Me personally, I'm not a big fan of the Kim test or the something like, but the load and shift test is really important. If they're sliding out the back and they're clicking and clunking, that's a big deal to me, because most athletes are subluxers; they're not dislocators.
Yeah, I mean, those are apt words. And certainly, I think you define what you're looking for before even undergoing imaging. But as we know, there's a spectrum of instability lesions. And I'm kind of curious about what's your imaging of choice. We have multi-directional laxity, we
Yeah.
have unidirectional instability. Jim,
So
where do you go
mine is
first?
this. Mine is this. I have a great guy that we've been arguing for 20 years. He's a really good reader named Jeff Powers. So we use an Aber. Everybody gets an Aber. Nobody gets a dye. We are not a dye people. I just don't like it. I don't think it's good for the cartilage. So we do a typical MRI and we put him in Aber, which is abduction, external rotation, and we watch how the labrum in the posterior aspect, especially posterior superior, leads. So the biomechanics, I'm just going to touch a little bit on. There is a rip stop at about 10:30 in the back. You cannot capture the biceps. If you fix them and capture the biceps, you've ruined them. So there's at the top of the equator is a tension band, and below the equator of the glenoid is an organ of compression. So above that, the labrum attaches on the side of the glenoid and there's a tension band and it's mobile. Below that, the glenoid is, or excuse me, the labrum is 4 or 3 millimeters on the face of the glenoid, and that's an organ of compression. You have to put them where they belong surgically, or you're gonna take a major leaguer and put them in the minor leagues. But if you come to the root of the biceps and start messing around up there, nope, that is not good in athletes.
Can I follow up a little bit with you, Jim, on this? Because I think this is so fascinating. When you say it's a tension band, you mean
Yes.
the biceps pulls on the top of the labrum? In what way is it a tension band? Just clarify that for me.
So when you're an athlete and you throw, especially, the biceps, the superior biceps, because of the biceps, when it works in throwing, it has to be a tension band. All right, it has to do that, or you can't throw well. My point is, if you capture the biceps above that 130 or 1030 position at the rip stop, and Ben Kibler's shown this, then you basically kind of ruin what it does. So when the biceps, the labrum tears at the top, as soon as it hits the posterior band of the anterior inferior glenohumeral ligament, it becomes unstable because the bottom part can no longer have a concavity compression, and now the shoulder's wobbling all over the place. Once you restore that, and you have to restore the top different than the bottom. The top, you basically put on the side of the glenoid, and not big sutures, and you can't touch the gutter. If you touch the gutter, you're basically making them not a thrower. In the bottom is totally different. In the bottom, you have to take that glenoid and put it on top of the labrum so that concavity compression works. And Bain, the guy that described this, is a guy named Bain, who captured Ben and my interest a long time ago. So anyway, I don't want to talk too much.
So I guess to make sure I understand it, are you saying that like there are throws in which the tear extends posteriorly, and then when it destabilizes the shoulder?
Yeah, we wrote that. Shane Sroyer and I wrote that in 2007 in AJSM.
And where?
And we said,
where is that? Is that 1030? Is that 9? Like where on the glenoid is
this? This is what we said. We postulated back then, and weren't sure, that in throwers especially, the tear starts at the top like a 2B slap, and once it extends into the posterior inferior glenohumeral ligament, the band, that's when it destabilizes. And it destabilizes, and it's called a lambda tear. And John Conway and I described that at Aerodicus, I don't know, 3 or 4 years ago, when it kind of splits. It looks like an upside down Y. And once that happens, you can't throw. I mean, you go high and outside, can't throw a slider, you lose velocity. And this is totally different than a football player dislocating the shoulder posteriorly. Because a shoulder that's dislocated posteriorly has big capsular rents, and no one understands that. But if you get somebody that goes out the back as a football player, you better go in there and start looking for these big rents in the capsule, because it's totally different than a thrower.
Guys, can I just go back to something that Dr. Bradley said a minute ago? Jim mentioned, if you have positive exam findings and kind of discussed the value of attempting physical therapy. I think that's a really interesting point that I think we've made a lot of strides in over the last few years, because I remember early on in practice, and I'm sure you guys have felt the same way, where you have an MRI confirmed posterior labrum tear, and you wonder, am I doing this patient a disservice by even trying physical therapy? Does it work? Is it worth it? What are the long-term implications? I think we still have a long way to go, but I think we've found recently through Dr. Bradley, John Dickens, and others have found some ways to predict who is going to need surgery and who maybe can be successful, at least in the short term, with non-operative treatment. There's a series out of Mayo that shows about 50% of diagnosed posterior labrum tears go on to need surgery over time. We've seen that in the military as well. In a 3-year cohort of posterior instability with 160 patients, about roughly 50% went on to need surgery. And what's interesting is we found that some of the exam maneuvers that Jim talked about, and then if they have a history of trauma, if they have a history of feeling unstable, and if they have certain imaging findings, we can discuss those if you want. But there are predictors that kind of help us figure out which patients are likely to improve with physical therapy and which ones are likely to fail. And at least in our series, in a couple of different series, it's been about 50-50 who walks in the door with a posterior labrum tear and who ultimately is going to need surgery, who won't. The interesting thing is that we did a follow-on MRI in the cohort that we looked at with shoulder instability that failed non-operative treatment. And if they felt like they were subluxating, there was discernible bone loss on the glenoid a year later with repeat MRI in a substantial number of those patients. So it's something that we got to think about. If we choose non-operative treatment, what are the long-term implications? And I think there's some room for improvement in terms of our body of knowledge there.
So,
Well,
so tell us,
the paper that's a seminal paper is written by Justin Arner, Matt Preventure, and I was involved in it. And we found out that if you have 11% bone loss, you have a 10% chance of failing. If you have 15% bone loss, you have a 25% chance of failing. And retroversion in our study didn't make any difference at all. So it's bone loss or a small glenoid. A smaller glenoid is a really bad thing in this. And the Matt and Justin Arner and those guys wrote those papers along with us, and so that's what I go by. Bone loss or small bone width is a big problem.
So is that true for you for non-surgical treatment? Basically, if you have no bone loss, you feel like those are the patients where maybe there's some opportunity for non-operative treatment? Like, what does the non-operative treatment patient look like?
Yeah, so here's our problem. If you send them to therapy, they use up all their therapy, and then they don't have any therapy afterwards for after you operate on them. So I use, the history, it's amazing. Like, MRI to me is my second choice. Physical exam is my first choice. If they have 4 out of the 5 tests that we do, and they're sliding out, they're not going to get better with physical therapy. They're just not going to get better. But it's been we've got significant amount of confidence intervals that say they're not going to get better. But the insurance companies want you to rehab them, and then they use all their insurance, and then they've got to pay for it afterwards. So when our paper is going to come out, I don't know what's going to come out. We just accepted it. But to me, history and physical is way more important than an MRI finding to me.
I couldn't agree with you more. And oftentimes it's just a confirmatory thing that you need in order to exclude some of the other concomitant pathology. I think before we leave this conservative discussion, Lance, who do you think is the person that's going to be predictive of success? Who is it? The malpositioned scapula? Is the people that have movement abnormalities? Is it the atraumatic individual that's a non-collision athlete? Help us understand for our audience.
Yeah, I think, at least in what we've looked at in the military population, is the patients that present primarily with pain, insidious onset of pain, patients that Kim and jerk tests we did not find predictive, in the need for surgery versus, those who did well with rehab. What did predict was an identifiable traumatic event that started their symptoms, complained of instability more so than pain. And then, certainly scapular kinematics, if you can improve that, the non-contact or collision athlete, they're more likely to do well with physical therapy. I think, I worry about the offensive lineman that has an acute traumatic event that feels unstable, that wants to continue to play football. It's really hard you really can't brace posterior instability. They're pretty maxed out on their rotator cuff and periscapular strengthening, usually if they're a big offensive lineman. So I worry about those patients. They're typically going to need surgery. And we've looked at that. And if you've got an athlete that's in season, they're an offensive lineman, there's an 80% chance of surgery. They're 80% chance that they're going to want surgery either during the season or after the season's over. So high likelihood of needing surgery in that patient population.
Yeah, so let's go there next. Transitioning to surgical management. Jim, the evolution of your approach to this is amazing. Obviously this discussion started with 1993 and we've followed your publications over the time. What are the key must-do techniques or pearls in order to ensure success of this capsular labor repair for true posterior shoulder instability?
So are we talking a traumatic dislocation or are we talking repetitive subluxations?
I think let's go with the latter because that tends to be what I see. I'm not sure about you.
Yeah. You mean traumatic or repetitive subluxations.
Yes.
So I agree with Lance that what we try to do in the NFL is get them through the season because I know I can fix them at the end of the season. The subluxations depends what sport they're in. So we've done a big study on that, and what we found was that my failure rate of this group, the highest failure rate I've had at 15.5%, are underhanded female pitchers, softball pitchers. Actually, overhanded players was only like 4% recurrence rate. And so my technique in that group is above the equator, I use suture tape and I use push locks. And I just try to get the labrum back on the face or the side of the glenoid, and then I rotate their arm out of the device that we hold them up with to make sure that I'm not over constraining them. And then in the bottom part, I take much bigger bites to make sure that labrum is on top of the glenoid. Now, if I'm doing a football player, it's kind of totally different. Because football players, if you tighten them a lot in the back, especially offensive linemen, they love you because they can hold better. They can hold their arm there and not get their arm outside the plane of their body, which causes them for holding. So I'm much more aggressive in those guys, and I'm much less aggressive in throwers.
And position on the clock face, amount of capsule imbrication. Are there any tried and true lessons learned there?
Oh yeah. So throwers, you cannot go in the gutter superiorly. You can't go there. That's not where you just need to put the labrum on the side. Down low, you can go there. In contact athletes, you can go up high, you can go higher, you can go into the gutter. Down low, you can go in the gutter. And my bites are much, much bigger. The one pearl I'll give you is this. If you truly have an athlete that posteriorly dislocates, playing, you better make sure when you go in there, you're ready to fix the capsule. And the question is, do you fix the labrum first or you fix the capsule first if they have tears in both? What I do is I fix the capsule first with sutures so I don't over tighten them and then I fix the labrum. Some people like to do it the other way, but I found that if I fix the labrum first, I may not have enough kind of girth or room to fix the splits in the labrum, and there's usually splits in the capsule, and there's usually more than one split. So I fix capsule first, and then I go to the labrum.
And to clarify, this is absorbable, or non-absorbable.
Yeah, that's exactly what I was.
No, I use in the capsule I use non-absorbable, interrupted sutures, and I don't tie on the glenoid side, or on the the joint side. I will interrupt it, invert them, and tie outside the capsule, higher, lower, it doesn't matter. On the bottom, I've always used, it's called suture tape, and the reason I use suture tape is because the main part of the tape is polyethylene, which is really, really strong. But the body does not like polyethylene, but the outside of it, because it doesn't cover. The outside of the suture tape is polyester, and the body will cover that very well, that you won't get any squeaking or things like that.
Yeah, those are great pearls. Lance, do you similarly tailor your treatment based on underlying sport or activity profile?
I do. I'm very similar to Jim. If I've got an overhead throwing athlete, I try to do more of an anatomic repair of the labrum to get the labrum back down where it belongs, but less of a capsular tightening. If I've got a contact or collision athlete that's not an overhead throwing athlete, I take more of the capsule, I tighten more of the capsule, try to recreate that PIGHL, taking more of the capsule, getting the labrum still anatomically reduced back onto the glenoid, but definitely taking bigger bites of capsule. If they've got a posterior or reverse Hagel, I tend to fix that, just like Jim mentioned, so I don't over tighten and ball too much capsule first as I'm doing my labrum repair. So I would fix that reverse Hagel first, then come back and do the labrum at the end. If there's a capsular rent, I'm about 50-50, just depending on how that capsular, like intracapsular tear presents. Sometimes I'll fix the labrum first, then close the capsule on the way out. Other times I'll fix the capsule first if I needed to dial in my labral repair and capsular. But I do tailor it depending on the sport and the activity that they desire to get back to. I'm similar to Jim. I use knotless, and I use labral tapes. I think the capsule thin posteriorly, so I'm trying to get as much of a hold in that capsule as I can. I do think tapes, and we've looked at this biomechanically, I think the tapes offer a biomechanical advantage, higher pull-through strength required to pull through that posterior capsule with the tape. So I do think combining the tape with the knotless provides a good advantage, especially posteriorly.
But we've talked at this point about kind of the soft tissue repair. As we've talked already, there are patients with attritional bone loss posteriorly. I think we're all familiar with that on the anterior side, but it's often under-recognized on the back. So maybe talk to us first, Lance. How are you evaluating for this? Is like every patient get a CT scan? Are you always doing 3D recons? Like, are you measuring with a perfect circle? How in clinic do you handle that?
Yeah, I think that's a great question, and certainly we've learned a lot over the last few years because of so many people that have contributed to this. And I think first we go back to the history and physical. If you've got somebody who's had long-standing symptoms, multiple subluxation events, you just have basically every time you see somebody with posterior labrum tears or posterior instability, you have to be looking for it because it does present a little bit different than anterior. So Matt Preventure and Travis Decker showed us that on the clock face, if you think posterior inferior, kind of that posterior inferior quadrant, kind of that 8:30 position is where you'll start to see some of that bone loss, and it's obliquely oriented. It's not along the long axis of the glenoid. It's obliquely oriented, and so you have to look for it on your MRIs. I do an MRI, and I'll do an en-face view of the glenoid, and I'll really scrutinize because it can be a little more subtle than the anterior at times. I try to measure the surface area and then subtract the surface area bone loss. If I don't have the technology or the software to do it on whatever system I'm working on, then I'll use perfect circle technique. One thing that's also different about posterior bone loss is you can have sort of an inclination, a reverse inclination, where you kind of have a kind of a concavity posteriorly, especially if they've had prior instability surgery and they've failed. Be on the lookout for not necessarily volumetric bone loss, but the loss of concavity posteriorly, and that essentially is functional bone loss that way. So I do think you got to look for it. You got to know where to find it, and it does present a little bit differently than the anterior bone loss. And so, if I've got somebody who is in that, like Jim talked about, that magic number of 10 to 13 or even 15, if I've got somebody over that amount and I'm potentially thinking about bone grafting, then I'll get a CT just to really make sure I quantify that and understand it.
Jim, are those the numbers you're using too?
So, a couple of things. So I have a patient population that's a little different, and there's no one in the NFL that's ever come back from a distal tibial allograft posteriorly that I know of. So I'll do everything I can in those high-level guys. Once they get around 11%, 10%, I will actually take the capsule and put it on the face of the glenoid. So I will basically shorten their joint by doing that, realizing that I don't want to put any bone back there. I mean, for people to get, seizures and stuff, that's totally different than my population. I have a large group, and I've done a whole bunch of people kind of doing it that way, and I've been kind of really happy with this. And the other thing I can tell you is everybody thinks retroversion is a big problem. Not in my group, it's not a big problem. It's just not. I mean, we did not have any increased failures with retroversion, even in the throwers. So I will do anything I can not to put a piece of bone in the back of the shoulder unless they grossly fail.
Similarly, one of the taboo aspects traditionally for me has been how to incorporate the reverse hill sacks. So is that off limits as well, or is that somehow more conducive than a bony operation, Jim?
Yeah.
Whether
So a
that's
reverse
reverse
remplissage is what you're talking
remplissage.
about. Yeah. Oh
Yeah.
no. I'll be all over that if I thought that was an issue, because I think that's a really good operation. You know what I mean? It's arthroscopic and you can train the shoulder. But I will not do that in a thrower. That's a contact athlete problem. You do that in a thrower, I'm a little concerned. Even though remplissage anteriorly has been shown that their rotation comes back, but that's a little concerning to me personally. And in my patient population, I don't have a lot of that.
Hmm. And so what's that operation look like for you? How are you executing this? Is it MGHL? Is it subscap? Is it capsule? Maybe walk us
You
through
mean
that
you mean the
briefly.
reverse
Yes.
remplissage?
Yes.
It's just the subscap. That's all it is.
Okay.
Two anchors, same way we do it in the back. That's kind of the way I've done it. I haven't bought. Well, I'm feeling a prejudice here. I haven't really bought in to the remplissage for everybody like some people have. I haven't done that, especially in some of my athletes. So I'm a little different, but I think I can stabilize them the old-fashioned way.
Yeah. Yeah, Lance, any thoughts on this? How are you executing that? We know it's much more articular in nature when you have the reverse hill sacks. And again, we're not talking about the seizure patients. Those tend to be a little bit of a different animal. But in your collision or athletic patient population, are you moving towards some sort of anterior management alongside your traditional capsulolabral repair?
Yeah, I think I'm not certainly not doing a modified McLaughlin or reverse remplissage nearly as often for posterior as I am the remplissage for a classic Bankart. I think some of it has to do probably with the nature of the beast. In terms of there's really just we're dealing more with subluxators and micro trauma than we are true dislocations. So it's harder to get that reverse hill sacks lesion to begin with. And so, I know some folks are advocating for even if there's a small hill sacks in the setting of this is conventional anterior labrums or Bankarts, either doing a remplissage in a small hill sacks or either even creating the hill sacks and doing a remplissage there. I think I'm certainly not doing that in the posterior setting. I'm not creating a reverse hill sacks lesion to do a modified McLaughlin. It's been very rare that I've done a modified McLaughlin just because I don't see that many reverse hill sacks lesions. I think if you are worried about somebody and they've got a reverse Hill-Sachs lesion, I think it's a very good operation to do. I just haven't seen it that frequently.
We've talked about the bone now on the humeral and the glenoid side. The next frontier, the newest frontier, is the acromion. Right? And there's all this evidence building, after Christian Gerber's work in Switzerland about how the acromion potentially contributes to posterior instability. So the question is, are either of you including this in your evaluation and treatment paradigm? And if so, how? Like, what does that look like? How do you measure it? What are you doing about it? Jim, is this for you at all or no?
So Christian Gerber wrote that article. I looked at it and I said, I'm not so sure about this. So then we looked at ours. Justin Arner, my partner, we looked at ours, and there was a difference between a Swiss Chalet and a flat glenoid. The Swiss Chalet tended not to have revisions. It didn't go out the back, but if you have a flat top glenoid, it's an anatomic variant that you really don't want with posterior instability. So we look at, and we're doing a big study on all of my patients, and we're going to look at that and publish it. But that's something I look at all the time.
Yeah, I would echo that.
Like, are you doing anything about it right now?
Well, I'm not doing an osteotomy or another. I'm just looking at it and saying, look, this has a higher rate of posterior instability and revisions. In our study, the Swiss Chalet ones were much better than the flat ones because it kind of blocks it from going out the back. So right now we're not surgically doing anything, but it's really on our minds, and we talk to the patients about their the anatomic area of their acromion. I talk to them and say, look, you have a higher recurrence rate based on your anatomy.
I totally agree. And I think it does help, for me, it helps me in my decision making for some of those tweeners. If somebody has got, they've either had a prior repair that's failed, and they've got a high and flat acromion, I'm probably going to be a little more aggressive in adding bone, especially if they've got that tweener bone loss amount, if they've got mild to moderate bone loss and they've got a high flat acromion. We've seen in our patients they're much more likely to fail their arthroscopic repair. So I'm a little more aggressive in adding bone posteriorly. We have found we are cautiously optimistic in our military population in terms of the arthroscopic distal tibia allograft. Obviously, that's a much different beast than the NFL. But we've looked at our preliminary results in 25 of those patients, and they've done well with one patient with graft resorption, another with recurrent instability. But the majority, at least in short-term follow-up, have done well. So if I use it for counseling patients in terms of their risk of failing non-operative treatment, but also recurrence of the instability. But it also helps me with my decision making if they're one of those patients that could go either way, either with a revision or with a bone grafting. It does inform my decision making if they have a high flat glenoid. No, sorry, high flat acromion.
Yeah, just to clarify, we're talking about acromial morphology with that flatter archetype or that flatter morphology.
Yeah, I think, and we're really indebted to Dr. Gerber for showing us that, because we've, just like Dr. Bradley, we've looked back at our patients and we really found that to be predictor of, if you have that high flat acromion, that's a predictor of failure for so many things, whether it's a primary or revision setting.
Well, Peter and his partner Bob Tashjian get really excited about this topic, so I really need to veer off until we start talking about the modified Scapinelli technique and some other things. But there's more meat on the bone here. I agree. But I think probably a more tangible topic for our audience is really talking about rehabilitation. I mean, in my mind, I think anterior and posterior labrum tears are really fundamentally different. But Jim, I'd love for you to walk us through your post-operative care protocol and maybe offer in some pearls about how do you discern readiness for return to pre-injury activity when it amounts to lining up on Sunday and taking on another 300-pound guy.
So I'm a simple guy, so I make it like a house. We're building a house, right? So the first 6 weeks, the foundation of the house has to get sticky, right? So we have to have a good foundation to build the house. Then the second 6 weeks is all about synchronous range of motion. You know, there's 17 muscles that attach to your scapula, for Christ's sake. So we think the scapula is the foundation of the shoulder. So we make sure in the second 6 weeks, we don't give it really a lot about strength. We care about scapular kinesis and making sure it's doing well. Then the next 6 weeks about that, we just beat them up strength-wise. You know, blood flow restriction. I'm a big fan of that. You know, we started that in Pittsburgh a long time ago, and you get that little boost in your growth hormone. So we really strengthen them significantly. And then in around 4 months is the roof of the house. And that's where we start sports-specific activities, and we move them along as fast as they can go. And some people, we slow them down. And I can tell you, we're starting to give them, supplements. I don't want to make any trade names here, but all the Steelers that I operate get on a special supplement thing that we start right after surgery so that they have peptides, amino acids, they have creatine, they have vitamin A, vitamin D, everything they need, 13 things they need to heal. And it's perfectly legitimate in the NFL. I'm just not going to say the brand name. But anyway, we do that all the time. And my guys now, because my players have been doing so well on it, we've been starting them on that to make sure that they are ready to heal. And there's multiple studies out there that said most people we operate on, only 10% are really ready to heal their wounds because they're functionally, they're not ready based on a lot of the things they're deficient in. So we've been doing that. And my end range, most of my athletes at 6 months are ready to play. So that's kind of, and I explain it to them in those terms, like very simple terms. I have a guy in my office that is a kinesiologist, and he can tell me, I just send him to him, put him on the force plates and everything, and he can tell me where they are so I know who to push and who not to push. And that's kind of what I've been doing for the last 4 years.
I think
Maybe I
that
could follow up with you on one little detail. It sounds like at the beginning you're trying to make things sticky. That's the foundation. What position are you immobilizing patients in, or are you doing that at all to try and get that stickiness, or does that detail not matter?
No, so we have a sling with a pillow, and we keep them in external rotation. But I move them early. I don't like lock them down at all, but I kind of keep them in that for like six weeks or so. But I'm doing therapy. I'll start therapy the third week, so I give them 3 weeks to get sticky. And by the next 3 weeks, I hope the cement's hard enough for them to do anything. My only point to you guys is the scapula is really, really important. So if they're not moving their scapula appropriately, you're kind of screwed. So you got to really work on their scapula.
Lance, did you have a follow-on comment? Sorry.
Yeah, I was just going to say I really appreciate Jim's comments there, because if you look in the literature and you're looking for guidance on this, so often the return to play criteria that's published is based on time, and the most common time that's published to clearance for return to play is 6 months, and that's the quote unquote objective criteria that's out there in most publications. And I think there's a real opportunity to do a lot of the things that Jim mentioned. I'm really interested in looking at force plates, looking at kinesiophobia scores, looking at objective measures of upper extremity strength, looking at their scapular posture. We've really got an opportunity to try to create some objective measures for trying to set a standard for when patients are truly ready to return to play, rather than just saying, hey, we're 6 months into this, you're ready to go. And I think I really appreciate Jim's comments there on some of the ways that he does this above and beyond just looking at the calendar.
Well,
the only thing go ahead.
Okay, sorry.
No, I was done.
So if you look at my ACLs, I do a boatload of ACLs. And I can tell you there's a huge spectrum of when people go back. It's genetics. It's their muscles. Is their tendon ready? Are they small? Do they have a small tendon? Do they have a big tendon? I mean, there's so many variables. But what we do is we will test every one of those in our office with our force plates, and they will tell us where we are in their tendon and where they are in their muscle. And the shoulder's the same way as my ACLs, because everybody's not the same. And as Lance said so appropriately, this is not a cookbook. People are genetically different, and some people are, they're all pros and super healers, and some people are going to take a year. And our job is to find where they are.
Well, guys, this has been a tour de force. I mean, it's been just phenomenal to hear your insights. I really appreciate both of you spending the time this evening. It's great to hear all of your insights from the beginning of the history and its importance and the details of the surgical technique and the nuances of bone loss and the 3 different areas we looked at. I really appreciate all of your efforts here to kind of unpack this controversial and still changing area of shoulder and elbow practice. For all of our shoulder and elbow listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.